This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the Croatian Medical Journal, published in 2026. It's a volumetric MRI case report titled Craniospinal Cerebrospinal Fluid Volume Changes After Extreme Bilateral Frontotemporoparietal Craniectomy and Cranioplasty.
This is a particularly interesting case, Alara, because it deals with something we see quite often in the trauma bay, decompressive craniectomy. But it investigates it through a very specific lens, the total volume of the craniospinal axis. Usually, we're so focused on the intracranial pressure that we forget about the spinal compartment.
Exactly. And this case was quite extreme, as the title suggests. We're talking about an 18-year-old woman who was a pedestrian hit by a tram. She presented with a left frontotemporoparietal, or FTP, acute subdural hematoma and extensive skull fractures.
Right. And the management was a bit of a cascade. She had an emergency left FTP craniectomy first, but then on postoperative day 1, a follow-up CT showed a new 20mm thick right-sided epidural hematoma with a midline shift, so they had to go back in for a right FTP craniectomy,
leaving her with a massive bilateral skull defect. What's striking in the report is how she developed a pronounced sinking skin flap syndrome. For the residents listening, that's also known as the syndrome of the trephinide. It's that atmospheric pressure-driven collapse of the cranial compartment, where the skin literally bowls into the brain defect.
It's a clear indication that the bone defect itself becomes an independent pathophysiological factor. Even when the intracranial pressure is technically normal, the lack of a rigid container changes everything. Now, Alara, let's get into the heart of the paper. They didn't just do standard imaging, they did full neuroaxis 3D craniospinal MRI.
That's the unique part. They captured the whole system, head and spine, before and 3 months after she received custom bilateral cranioplasty implants. This allowed them to quantify the exact volume of CSF in both the cranial and spinal compartments.
Let's look at those numbers. What did they find before the cranioplasty, when the skin was still sinking?
Pre-cranioplasty, the cranial CSF volume was 100.8 milliliters, and the spinal CSF volume was 78.2 milliliters. That's a total craniospinal CSF volume of 179.0 milliliters.
And after they restored the rigid box with the cranioplasty?
It's a significant jump. The cranial CSF volume increased to 152.7 milliliters. That's a 50% increase in the head alone. But interestingly, the spinal CSF volume also rose to 91.1 milliliters. The total volume went up to 243.7 milliliters.
So a total net gain of 64.7 milliliters of CSF just by putting the bone back. And the authors noted there was no relevant change in the brain parenchyma volume itself, right?
Correct. The brain volume stayed stable. The gain was purely in the fluid compartments. This suggests a global redistribution and expansion of neurofluids once the cranial boundaries were restored.
This is where the paper gets into the why. For our audience, this is a deep dive into CSF physiology. Traditionally, we are taught the classic model. CSF is secreted by the choroid plexus, flows unidirectionally through the ventricles, and is absorbed by the arachnoid villi into the dural sinuses. But the authors argue that this traditional model has a hard time explaining a 65 milliliter gain in volume just from closing a bone defect.
They point toward the Bulat-Klarica-Oryashkovitz hypothesis. This model views CSF, intravascular fluid, and interstitial fluid as a single hydrostatic and osmotic capillary-driven system. Basically, it's not just a fountain of fluid, it's a system governed by capillary filtration and reabsorption along the entire craniospinal axis.
Exactly. From this perspective, the large cranial defect in this patient was a natural experiment in cranial compliance. When the skull is open, the brain is exposed to atmospheric pressure. This shifts the neurofluid distribution between the capillaries, the interstitial fluid, and the CSF.
And the paper mentions animal models where a bony skull defect shifts the intracranial CSF pressure toward atmospheric values when the animal is upright, even while the overall cranial spinal pressure gradient is preserved. When we perform a cranioplasty, we're essentially restoring the closed box physics, which allows the CSF volume to expand back to its physiological state.
It's a powerful argument for the syndrome of the trephinide being a fluid dynamics issue. The authors suggest that this quantitative craniospinal volumetry provides in vivo support for these contemporary concepts. It's not just about protection or aesthetics, it's about the physiological environment of the entire central nervous system.
I found it impressive that despite such a severe injury, she even had grade 1 diffuse axonal injury, the patient had a remarkable recovery. After her rehabilitation and the cranioplasty, she was able to finish high school and actually enter university.
It's a great outcome, but from a surgical planning perspective, how do the authors see this data being used?
They suggest that understanding these volume changes might help guide the timing of cranioplasty. If we can see the fluid dynamics shifting or the system collapsing volumetrically, it might argue for earlier intervention to restore that hydrostatic balance.
It also highlights that we shouldn't just look at the brain in isolation. The fact that the spinal CSF volume increased by about 13 milliliters after a cranial surgery shows how interconnected the system is. You change the pressure-volume relation at the top, and it reflects all the way down to the lumbar system.
It really challenges the idea of the fixed cranial compartment when a defect is present. The paper calls a craniectomy a transformation of a rigid space into a partially open system.
Which is why the sinking skin flap is so much more than just a cosmetic issue. It's a sign of abnormally increased cranial compliance. By closing it, we aren't just putting a lid on, we are repressurizing a system that relies on those rigid boundaries to function.
To summarize for our listeners, this case used 3D volumetry to prove that cranioplasty leads to a significant increase in both cranial and spinal CSF volumes, nearly 65 milliliters in total, without changing brain volume. This supports a capillary-driven hydrostatic model of CSF, rather than just the old secretion-absorption pump model.
Very well put, Alara. It's a reminder for all of us in the OR that when we take a bone flap off, we're changing the fundamental physics of the entire neuroaxis.
That's all for today's episode. We hope this gives you some food for thought the next time you're looking at a post-craniectomy CT.
Thank you for joining us on the Neurosurgery Hub podcast. We'll see you next time.